So, dear colleagues, I'm happy to introduce our first spring webinar, developed by European Federation of Internal Medicine Multimorbidity Working Group. The topic of the webinar seems to be polypharmacy. My name is Jūlija Voicehovska. I'm professor of internal diseases department from Riga Stradiņš University, Latvia. And today I have a pleasure to give a short overview on polypharmacy in patients with multimorbidity. And I'm happy to introduce my colleague, Professor Václavik from Czech Republic, who also is introducing, giving a lecture on polypharmacy related problems. So,
good afternoon, everybody.
Hello again. So thank you for joining us today. I'm sure that a topic that we are discussing today is enough interesting and significant way to pay attention and induce a discussion. I remind you that after every lecture, actually we have two topics to be provided during today's webinar. So after every lecture, we are ready to, and we will appreciate your questions and will be ready to answer the questions. You may submit questions or using either chat or question answer setting. So thank you again for joining. Looking forward our further discussion, and let me begin with my topic, which is again polypharmacy in patients with multimorbidity. I will focus on epidemiology and impact. So I start to share my screen. So I hope it's okay. And before we begin, I would like to emphasize again the significance of the topic, since for various reasons polypharmacy has drawn much attention recently. It has become a normal aspect of modern medicine, and actually polypharmacy might mean that we are skilled enough to target several problems in our patients. This phenomena of polypharmacy is driven by an aging, by application of medications in multimorbid population, by increasing availability of preventative medications and increasing use of single disease guidelines that unfortunately make approach to multimorbid patient difficult, more complicated, and resultant in maybe undue polypharmacy. So there are several points of view. So from one side, it is an achievement of such skilled approach, and from another side, it may be a lack of collaboration. Polypharmacy, unfortunately, is associated with a range of adverse outcomes and is considered an important and increasing challenge for clinical practice. We believe that polypharmacy requires more evidence-based knowledge and effective practice. It's time to discuss this. So key points I am going to cover during my presentation is a question about definition, what indeed is considered as polypharmacy. I will revise information regarding epidemiology and burden, emphasizing causes and impact of polypharmacy. I also would like to pay some attention to consequences that derive from polypharmacy in chronic kidney disease patient. So as well as we'll mention opportunities to prevent, as well as gaps in knowledge regarding the topic. Why did I decide to participate in this webinar? I would like to refer for a clinical case from my personal practice. I am sure that many of you health professionals might remember a similar case and not single one, unfortunately. So a female patient, 85 years old, was admitted due to loss of consciousness at home. On primary survey, her general condition was very severe. Patient was lying, passive and frail. Respiratory rate was 20 times per minute, oxygen saturation of 90% beyond oxygenotherapy. Diuresis daytime accounted 250 milliliters per day. Glomerular filtration rate by MDRD formula accounted 10 milliliters a minute. So it was also hyperkalemia and anemia with hemoglobin 6 gram per deciliter, with heart rate 86, irregular, being confirmed by ECG, atrial fibrillation, hypotension, both-sided hydrothorax, and also atelectasis with infiltration. From past history, from previous records, information about arterial hypertension of first, second degree with target organ damage, AFib paroxysmal, sugar diabetes second type, insulin independent, diabetic nephropathy, chronic kidney disease 3-4. Before admission, I mean, it is from past history. Secondary anemia, heart failure second functional class, and hypothyrosis. Yeah, so these were previous records. As well, we also got notes from family members about medications that are being used by this 85 years old lady daily. Yes, so, and since these are private notes, also doctor who has prescribed the medications, namely this is nephrologist, neurologist, endocrinologist, cardiologist, gastroenterologist, pulmonologist. And here I provide this list of medications, and you can see that both painkillers and anti-inflammatory non-steroid medications, as well as D-vitamin. By the way, it is in different versions taken. So also anxiolytics and also beta blockers as Concor and AC inhibitor, together with potassium saving spironolactone, on-demand cordarone, anticoagulant Xarelta. So of unknown indications, bronchodilators, Sericit and Biridol. So all in all, 21 medication a day taken by a lady. So how we managed the case, patient was dehydrated. We removed all the medications. There were indications to introduce a renal replacement treatment. So we stabilized fluid control, and actually conclusion that what was made beyond treatment management and following up, patient developed dehydration. So we assumed that since beyond heart failure, deterioration, dyspnoea developed, and undue administration of bronchodilators have been introduced, followed by further impairment of heart insufficiency beyond tachycardia. So all in all, dehydration with accompanied by toxic action of painkillers, anxiolytics, resulted in chronic kidney disease, acute damage, acute injury, let's say, followed by gastrointestinal bleeding, resulted in secondary anemia, deterioration, and this was a result. So unfortunately, such patient cases are being admitted. No, I can't say it is common, but it is often enough for we to pay attention and to respond to such situation in such loud voice, I would say. So from evidence, we know indeed that persons with heart failure, like patient that I introduced, they are to follow several treatment goals. They should adhere to a cardiac diet. They take cardiac medications on schedule. They are to monitor weight, breathing, and other symptoms. Very important is to follow fluid balance, so to monitor regular bowel habits, so avoiding constipation. So actually, person with heart failure should experience several challenges in the range just due to heart failure and some primary pathology like arterial hypertension or coronary artery disease. If our patient have a concurrent diagnosis of, for example, depression, he will he will have to take all of those steps mentioned above, while also remembering to attend psychotherapy sessions, take antidepressants medications, and practice cognitive behavioral strategies to manage daily psychological and emotional challenges. So actually it looks like a regimen of highly competitive manager. So, and this is phenomena of polypharmacy that might result in such inappropriate management. So when patient experiences challenges like simultaneous versus consecutive medications taking, short-term versus long-term therapy, prescription-only medications versus non-pharmacological products. So one more clinical example, patient with cancer, type 2 diabetes and history of atrial fibrillation will have to balance the effects of taking anticoagulants while on chemotherapy, has to follow diabetic diet while also eating extra calories to minimize cancer-related cachexia, has to manage unstable glucose level and hyperglycemia induced by steroid premedication for chemotherapy. So all in all, these are such obligations, whether we can recognize a point when polypharmacy, simultaneous take of several medications becomes a problem. So Monsoon and co-authors performed a systematic review of definitions of polypharmacy, and they discovered 111 numerical only definitions, 15 numerical definitions, which incorporated a duration of therapy, so and 12 descriptive definitions. So as usually, approach to evaluation of phenomena matters. So, and referring for majority of publications and results of systemic review, now we can conclude that there is no consensus, still no consensus on a clinical definition of polypharmacy. Term by itself derives from ancient Greek polos, meaning many, and pharmakeia, meaning the use of drugs. And most often polypharmacy is defined in terms of the number of medications. Indeed, taking 5 or more medications concurrently is defined as polypharmacy, but 10 and more is defined as excessive polypharmacy. So in some references, they emphasize also time slot, duration, for example, for more than 90 days, or in 1 month for 6 months or more in a year. So the potential for negative outcomes with the use of multiple medications in older people is well documented. And these are, first of all, adverse drug events, non-adherence, drug interactions. So in a review, in several reviews, I extracted the most common inappropriate prescribing in case of polypharmacy. And this is one of adverse effect of polypharmacy as a phenomena. So, this results from the situation that I mentioned in the beginning in my clinical case, when a patient is being monitored, followed up by several specialists, and there is no team that is supervising and managing a case, but patient is being treated and managed by different specialists. And this is why maybe inappropriate prescribing, like beta blocker in combination with calcium channel blocker verapamil, or aspirin with past history of peptic ulcer disease, and other situations that are mentioned here, estrogens with a history of breast cancer, use of regular as distinct from pro-renata opioids without concomitant laxative, and so on. So also problematic polypharmacy has been studied, and a systematic overview of published assessment tool have been performed by Kaufman and co-authors. And actually many tools are available decide about appropriate, not appropriate use. Some tools are recommended, are developed to be applied before prescription is performed. So in advance, we are advised to decide to make a decision how reasonable is this or that medication in this particular patient. So here I mentioned just several ones, but actually this table demonstrates reliability and relevancy of the tools, well-known Beers criteria that are being updated time by time, stop-start criteria. So you see that validation was supported by, performed in requirements with Delphi consensus. So this might be recommended. My colleague Jan Václavik will talk about these opportunities, how to evaluate polypharmacy, how to avoid polypharmacy. Yeah? So this is why I will not focus a lot on this topic. So just to emphasize once again significance of the topic. Yeah, so I would like to show you numbers reflecting burden of polypharmacy depending on definition and setting. So I remind you that actually there is no single definition, and studies result might depend on selection criteria. So, but all in all, we can conclude that up to 54% of older persons have shown to be affected from polypharmacy, and this number rises up to 79% in residential care. So a cross-sectional study published in 2015 conducted by Malknecht at co-authors and included 17 European countries and Israel, found a polypharmacy rate of 26 up to 39% among persons aged 65 and above. The highest prevalence of polypharmacy was found in Portugal, Israel, and the Czech Republic, whereas Switzerland, Croatia, and Slovenia were the countries with the lowest polypharmacy rates. So, and those researchers that have been studied drivers of polypharmacy mention indiscriminate use of clinical practice guidelines designed for the management of single diseases in elderly multimorbid patients. We know well that some guidelines suggest particular recommendations, like, for example, guidelines for the management of coronary artery disease, arterial hypertension in case of metabolic syndrome, and prediabetes developed by European Society of Cardiology. So we can't say that clinical practice guidelines are focused on single pathology only, but there are no, indeed, there are no guidelines that are being developed for multimorbid patients. This process is still going on. So, and such guidelines are being developed, but these are pending. Protocol-driven medicine that recommends prescribing medications at the first line of treatment and stepping up drug regimens with higher doses and or additional drugs if targets are not reached also result in such risk of polypharmacy. Performance standards and incentives that coerce clinicians to follow guidelines focused on starting medications, and as well as research gaps that leaves many aspects of polypharmacy poorly understood. So also we must mention inadequate clinician training, fragmented healthcare system, growth of the pharmaceutical industry, leading to an ever-increasing availability of medications and influence of the pharmaceutical industry on clinicians. So we should be aware about the patients, so target groups of patients who may benefit from an approach to care that takes into account multimorbidity, so the most vulnerable group. Yes, so those are patients that might feel difficult to manage their treatment or day-to-day activities, that receive care and support from multiple services, that have both long-term physical and mental health conditions, that have frailty or falls, that frequently seek unplanned or emergency care, that are prescribed multiple regular medicines. So not only in patient groups that I mentioned, now also in any patient who might experience polypharmacy, we are expecting many negative consequences. And these are adverse drug events, adverse drug reactions, drug-drug interactions. So I want to emphasize that actually presentation of polypharmacy negative consequences is quite diverse. So, and this is one of the points why should we re-evaluate need of every next medication that is being prescribed. Consequences might be hardly predictable, since these come from different fields. So actually, patient case, I began my presentation. Actually, we can find almost all these negative consequences. Yeah, so as patient experienced loss of consciousness, so and which resulted in disability, cognitive impairment, so this dehydration accompanied by malnutrition, so and eventually resulted in hospitalization. By luck, we managed to stabilize, and patient has been discharged with appropriate recommendations. So very helpful publication demonstrating the best clinical management tools when dealing with patients and polypharmacy. Yes, so we are recommended to pay attention. So there are a range of studies that underline the most important issues that need our attention, and these are interaction assessment, these are patients' preferences, so individualized approach, individualized management, and so on. So I began my presentation with a clinical case of polypharmacy in chronic kidney disease. So this group of patients seems to be one of the most vulnerable ones because kidney function might be directly impaired by means of particular medications that might be nephrotoxic, like non-steroid and anti-inflammatory drugs, or metformin, for example, so also anxiolytics, like bromazepam. German chronic kidney disease study reports that 20% of patients with chronic kidney disease take more than 10 different medications per day. So we should be aware about, by default, reduced kidney function and risk of overdosage in these patients. So this is why I believe we should be extremely careful when analyzing every next medication indications. So, German CKD study is not single one. There are also other results that report similar findings and arise this problem as quite significant. So number of medication intakes is reflected in this table. Yeah, so you see that actually 9, 10, 11, this is quite usual number of medications. And most commonly prescribed individual drugs in chronic kidney disease patients. So actually, it is the list that I demonstrated in the beginning in our patient. Yeah, so again, beta blockers, calcium channel blockers, several potassium saving medications. So, and as a result, patient was losing kidney function dramatically quickly. So this competing analysis reflects cumulative incidence of renal events in patients with polypharmacy, and indeed it confirms the idea that polypharmacy results in quite a high risk of not only kidney insufficiency progression, but also renal events and cardiovascular events. So, summarizing, what I would like to underline. So, we still have limited availability of reliable risk prediction models, despite these are available, but maybe not enough training and not enough implementation in clinical practice, as we know from the evidence. So there is still lack of feasible interventions of proven effectiveness and decision aids. There is limited consensus on appropriate outcomes of care, highlight major research deficits. So there is a need of integrated approach to both multimorbidity and polypharmacy, so that should be considered in future guidelines. Yes, so, and one of the messages shared by one of the tools for appropriate use of medications. So every time when you do prescribe, think whether you can answer yes to these 5 answers, whether it is right medication, right dose, right time, right route, and the right patient. So thank you so much. I'm happy to answer your questions, if any. So I'm revising contents of the chat. So sorry, I have to stop my share. And there are no questions in chat and no open questions. So if no questions, I'm happy to introduce again Professor Jan Václavik from Czech Republic. from Department of Internal Medicine and Cardiology, University Hospital Ostrava, and Faculty of Medicine, University of Ostrava. So who is giving a lecture named How to Rationalize Pharmacotherapy of Multimorbid Senior Inpatients. Please, Jan. Thank you.
Thank you, Jūlija. Good afternoon, ladies and gentlemen from the Czech Republic. So now let's have a look at what to do with our inpatients in our everyday practice. So it goes, okay. In the elderly, we see some physiological changes. They increase in body fat, they lose skeletal muscle, and thus have increased volume of distribution. And we also see decline in renal function, respective whether or not they have renal insufficiency. So those patients have decreased drug clearance. The consequences are that the drug half-lives are prolonged and drugs achieve a higher plasma concentration in older people. And also these old people have greater risk for adverse drug events. In older patients, we have several challenges in prescribing, because mostly these geriatric patients are excluded from clinical trials. So the approved doses and drugs may not be appropriate for all adults. We also see multiple changes in pharmacokinetics, like absorption, distribution, metabolism, and excretion, and also in pharmacodynamics. So if we prescribe drugs in the elderly, we should raise at least these 10 questions. Is there an indication for the drug? Is the medication effective for the condition? Is the dosage correct? Are the directions correct and practical? Are there any clinically significant drug-drug or drug-disease interactions? Is there unnecessary duplication with other drugs? Is the duration of therapy acceptable? And is the therapy the least expensive alternative compared with others? We also have the danger of so-called prescribing cascades. Sometimes a patient has an adverse drug effect, which is misdiagnosed as a new medical condition and treated with another potentially unnecessary drug. And then, of course, the patient is at the risk for developing additional adverse drug events related to the new and potentially unnecessary treatment. An example might be leg edema, which developed after treatment with calcium channel blockers due to fluid redistribution. Many physicians interpret them as a new condition and administer patient a diuretic, which is of course an error. Although not all edemas might be from calcium channel blockers, this one was because of gabapentin. So also other drugs may cause leg edemas. There are several other very frequent prescribing cascades, like antipsychotics lead to extrapyramidal signs and symptoms and lead to introduction of anti-Parkinsonian therapy. Use of thiazide diuretics may lead to hyperuricemia and doctors administer gout treatment. Also pain requiring NSAIDs sometimes increases substantially blood pressure and leads to intensification or introduction of antihypertensive therapy. So, in practice, what shall we do in our hospitals with the multimorbid seniors with pharmacotherapy? I would like to show you a case from our hospital. It's a 75-year-old lady called Vera. She had a fracture after a fall in September last year. And in October, she was admitted for stage 1 acute kidney injury of renal etiology. And then again in February, another acute kidney injury and symptomatic COVID disease. And she was transferred to our department on 7th of March from rehabilitation because of acute lower urinary tract infection. Here we see her past history. She has chronic kidney disease stage 5. She's in pre-dialysis. She has chronic coronary syndrome, had a myocardial infarction in 2004. She has paroxysmal atrial fibrillation, hypertension, dyslipidemia, anemia, hypovitaminosis D, struma, and large joint endothelitis, secondary hyperparathyroidism, hyperuricemia, and also had the fracture and also had COVID recently. So the step one is to review all current medications, to reconcile, and sometimes it's really necessary the patient brings it back where he includes all the drug he is using. We definitely need to know not only all the prescription drugs the patient is using, but also all the over-the-counter medications and supplements such as vitamins and minerals. We should get the information on the dosage and frequency of each medication, and possibly also on the duration of use, indication, patient experience of each medication, maybe side effects and their adherence. Here we see the drugs she was receiving when she came to our department. Cefuroxime, warfarin, metoprolol, amlodipine, losartan, urudipyl, furosemide, allopurinol, fixed combination of ezetimibe and atorvastatin, some amino acids, erythropoietin, sevelamer, paricalcitol, ferrum sulfate, sodium bicarbonate, magnesium lactate, kalium chloride, some flavonoids, vitamin D, metamizole, codeine, probiotics, which she got recently with the antibiotic therapy. She also has sipping of protein energy drink. She is receiving zolpidem once daily. She's receiving lactulose, and until recently she was getting buprenorphine and plastra for pain, and also she's using pantoprazole. So quite substantial number of 26 different drugs administered in 37 used tablets per day. We always have to see the bigger picture, how the medication use fits to the patient health status and diagnosis. What are patient goals of care, preferences and values? What's the patient's susceptibility to drug-induced harms? Are they frail? Are they cognitively impaired? Do they fall? It's all we have to consider. So if we match together, we can see a substantial number of drugs given for not so high number of diagnoses the patient has. Maybe you would like to see her blood chemistry. She has advanced chronic kidney disease with good blood filtration, 0.24 milliliters per second. She has high CRP because she is now having acute urinary tract infection, and she also has a mild anemia, and she was over-warfarinized with INR 4.13. She's also substantially frail. She needs a wheelchair to move around, and she's not even allowed to get on the wheelchair by herself. So she's quite dependent. Now we get to deprescribing. What is deprescribing? It's a set of interventions to identify inappropriate or unnecessary medications and discontinue them. In general, it's a process where we withdraw medication by our intention, supervised by a healthcare professional, and the goal is to manage polypharmacy and improve outcomes. The general goals of deprescribing are to reduce overall medication burden, reduce falls, cognitive impairment, and improve global health outcomes such as hospitalization and death, and also, very importantly, to improve patient quality of life. When deprescribing, the clinicians must consider many factors in prescribing decisions, but it's very important to use common sense and clinical judgment. And we not always can adhere strictly to all guidelines or criteria which were published. It's not always possible in many cases. In fact, our patient fits for many characteristics of a good candidate for deprescribing. She's multimorbid, she uses multiple medications, she has renal impairment, she has multiple prescribers, and she is also frail. So these are 5 reasons we should consider deprescribing this patient. So step 2. Now we have to identify any inappropriate, unnecessary, or harmful medications which have no valid or current indication, which are causing or contributing to some adverse drug reactions, medications which were started as a result of prescribing cascade, which are high risk in such population or ineffective, or are used for preventive indication in a patient with a life-limiting illness. So, how to perform a medication review? We have to talk to the patient or maybe to the guardian. So if there is some evidence for using the drug in the indication given in its current dose, in the patient's age group, disability level. If there is evidence, okay, we continue. If not, we ask further. Is the indication valid and relevant for the patient's age group and disability level? If no, we stop the drugs. If yes, we also ask about the possible adverse reactions of the drug and whether they outweigh possible benefits in such old disabled patients. Are there any adverse symptoms or signs which may be related to the drug? If there are, we can shift to another drug. Also, we can shift to another drug in case there is another drug which may be superior. If we do not have any alternative drugs, we can also consider reducing the dose of this particular drug.
Yes.
Interestingly, implementation of this algorithm led to discontinuation of 47% of the medications in a feasibility study, and no significant adverse events were attributable to discontinuation over a 13-month follow-up. In our head, we usually match the medication with particular diagnosis. So I matched it here in colors, antibiotics, warfarin for atrial fibrillation, then antihypertensive drugs for chronic coronary syndrome. In the green are drugs for chronic kidney disease, in the darker green, drugs for hyperparathyroidism, and in brown, drugs for anemia. Also, she has vitamin D, she has analgesics. So some drugs match with the diagnosis, but as you can see, there are several drugs in black which do not match any diagnosis. As Jūlija said, we have many papers, many different systems for identifying potentially inappropriate medications, such as BS criteria or the stop-start criteria, which I will turn to closer now. Which drugs generally should be deprescribed preferentially? The drugs they cause most harm, like central nervous system acting drugs, glucose-lowering drugs as long-acting sulfonylureas or insulins, then also proton pump inhibitors without strong indications, or chronic use of NSAIDs without strong indication, or aspirin in primary prevention. In our patient, the BS criteria do not help us much because they do not tell us any cardiovascular drugs we should withdraw. Also, this patient also doesn't use many CNS active drugs such as benzodiazepines. Although the BS criteria tell us we should potentially leave out proton pump inhibitors, which may be detrimental. In our practice, we tried recently to discontinue PPIs in many such patients. But the problem is that long-term PPI use leads to overproduction in gastrin, and after PPI discontinuation, we sometimes saw rebound phenomenon, and the patients return for recurrent peptic ulcers or ulcer bleeding. So, although there is no general way how to correctly deprescribe PPIs, it's potentially safer to decrease to lower dose first, and then use PPIs on demand, and then finally stop PPIs. So taper dose gradually and do not do the prescribing in one moment. So we see the PPIs are generally also mentioned in the stop criteria as drugs which should be withdrawn if there is no clear indication, and if patient had uncomplicated peptic ulcer disease or erosive esophagitis, they should not be administered for more than 8 weeks. Also, the stop criteria tell us that we should leave out drugs that increase the risk of falls, and our patient has fallen, had fractures, so she's using zolpidem, and this is another candidate for withdrawal. And in fact, in the BS criteria, they also say that in patients with history of falls and fractures, zolpidem should be considered to be withdrawn. So at this moment, we have left out 2 drugs, zolpidem, hypnotic, and pantoprazole. Is the patient using any anticholinergic drugs? No, she's not. She's not having any strong opioids leading to these problems or any CNS active drugs. So there's not a problem in her. But in general, and this is maybe the most important clue, we should consider stopping any drug which doesn't have a clear clinical indication. So if we look at her, she has allopurinol, she has magnesium lactate, potassium chloride, she has flavonoids, and she has probiotics. We know that the evidence is conflicting about probiotics. Some studies support, and this recent study, which I show on the right side from BMG from last year, showed that probiotics might prevent some antibiotic-induced diarrhea, but still in such patients I would consider withdrawing. Also, a recent trial in patients with chronic kidney disease didn't show any effect of using allopurinol to prevent chronic kidney disease progression, and generally in asymptomatic hyperuricemia, allopurinol should not be administered. What else? Any drug prescribed beyond the recommended duration, when the duration is well defined, should be considered to be withdrawn. In this case, I would consider leaving out the iron supplement because the patient no more has iron deficiency. I would leave out sipping, and I would leave out lactulose because she's not getting opioids now. Anyway, we get to cardiovascular drugs, and we know that centrally acting antihypertensive drugs are generally less well tolerated by older people than the younger people. And my experience that they are also quite less effective in the 5 or 6 combination in more severe or resistant hypertension. So I would suggest leaving out urapidil, but we also know quite well that fixed combinations lead to better hypertension control. And our study in about 200 patients with resistant hypertension showed that if we simplified the medication of patients, we get to a lower number of daily used drugs by 2 tablets daily, but more importantly, also their blood pressure control improved markedly with this simplification, simply because they had better adherence and used less drugs. So to simplify her antihypertensive treatment, I would give her metoprolol-succinate once daily and a fixed combination of telmisartan and amlodipine instead of amlodipine and losartan, and we've already left out urapidil. So what to start? These are the start criteria. They said we should start anticoagulation in patients with chronic atrial fibrillation, and we also should use antihypertensive drugs, and this patient has hypertension. And also we should use statins in patients with coronary artery disease and beta blockers with coronary artery disease. So these are the drugs we should keep in the medications because they really improve prognosis. The start criteria also say we should consider giving vitamin D supplement, at least in all the people who experience falls or with osteopenia, and our patient had experienced fall. So this is a case to use vitamin D. And the patient also has quite a substantial chronic pain. And we know that the stop criteria say we should first try less stronger drugs, but our patient, despite getting 2 weaker analgesics, she still had pain. So we tempted to get back to give her opioid again. And in case we get opioid, we should also use laxatives. So this is the change we made. We got back to Emplastra of buprenorphine, and lactulose was reinstituted, but we left out metamizole and codeine. So it's always important to talk to the patient, because this is essential to explain to the patient our plan, our goals, what we aim to when we want to deprescribe, what that the medications might be causing harm, and which drugs we would like to withdraw. And we can do it at one time or in several occasions, but it's always essential to ask the patients what are his opinion on medication stopping. There are also several possible handouts that can be given to the patients. This is the Canadian network for the prescribing, which is offering really nice handouts for patients. But not only communication to the patient is essential, but also communication to other clinicians who care for the patient. And if there are some mixed opinions, then we should achieve some consensus. But at least the general practitioner and other specialists should be noted about our changes. So we get to discharge, and we can see at discharge she's using warfarin, she's using metoprolol-succinate, a fixed combination of telmisartan amlodipine, furosemide, fixed combination of ezetimibe and atorvastatin. She's still using drugs for chronic kidney disease such as amino acids, paracetol, sevelamer, bicarbonate. She's getting vitamin D twice weekly, erythropoietin once monthly. She's having every 3 days Emplastra with opiate and lactose in constipation. And for 2 consecutive days, she also will be getting antibiotics. So we achieved withdrawal of 9 drugs and 23 tablets daily. The step 4, the final step, is to regularly review medications, because the prescribing sometimes may require tapering or medications may cause withdrawal symptoms. So the process needs to be monitored closely, and our patient was scheduled to go and visit her general practitioners 3 days after the discharge, or to have INR checked and their health status checked. And at least annually, preferably at every visit, we should look at all medications and think if all medications are really, again, indicated and should be administered further. So to conclude, optimizing drug therapy is an essential part of caring for an older person. It is essential in prescribing to continually reappraise the patient's medication regimen in light of his or her current clinical status, goals of care, and the potential risks and benefits of each medication. And we have such a stepwise approach. We should review almost every clinical visit the current therapy, discontinue potentially unnecessary therapy, consider adverse drug events as a potential cause for any new symptom. We should consider non-pharmacologic approaches, substitute with safer alternatives, reduce doses, and use other beneficial therapies when indicated. Thank you for your attention.
Thank you, Jan, so much. We have a question. First question is addressed to me, and it is question about real alert sign in polypharmacy, about 5, about 10, about 15. I believe that real alarm, excessive polypharmacy starts from 11, yeah? So above 10, it is indeed polypharmacy alarm. But don't forget that 5 is considered as polypharmacy by default. And in any case of polypharmacy, even when we administrate just single medication, it should be strongly reasonable. But once there are several ones, re-evaluate, especially in those patients that are vulnerable, elderly, multimorbid. So I see one more question that might be addressed to both me and Professor Václavik. So do you have any opinion about the future of compounded polypills actually manufactured in office pharmacists? One would be able to prescribe a customized drug cocktail that could be compounded in less number of pills. So if I share my opinion, so I believe that any compound, fixed combination or whatever should be transportable for available. So these contents and receipt should be available to healthcare professional, since we are to monitor medications that we are prescribing, and this is a lack of so many food supplements available with no prescription, and patients are taking some microelements, electrolytes, and we are not able to control neither dosage or chemical specific setting.
Yeah, I also would add that I'm also a big fan of polypills, actually, and I prefer fixed combinations as much as possible in my patients. And I've been treating quite a severe hypertension for several years, and I always try to offer patients, ask them if they would prefer using less drugs in fixed combinations, and I would say 99% of patients say yes, I want to use less pills, less tablets per day. So the patients appreciate it, and we see big effects and success with this treatment customization. So I'm a really big fan, and I think we should have many more polypills and fixed combinations of most frequently used combination drugs. I think it would be really helpful for our patients.
So we have one more question. What about auto medications? What is your experience? How to manage?
Which I don't see the question now, but
it is within question and answers.
Okay, I get there. Auto medication. Well, I don't know what Oliver what he means with auto medication.
Probably it is self prescription.
Prescription. I do not have personal experience with this self-prescription. We sometimes give patients some scheme how to adjust his medication, like antihypertensive medication. We give them advice: if you're feeling bad, you should do this, you increase this drug, or you withdraw this drug. So we give the patient some roadmap, what to do in a few steps, but and at a certain point the patient has to come to my office and say, okay, now we stand here, I'm doing this way, and I say, okay, let's do the medication like this. So maybe a few steps can be advised to the patients, but there must be some stops when the patients come back to the physician, I think.
Thank you. One more question from Maxima to you, Jan. What is your preferred tool which could aid in the prescription process? Any application or software which could use clinician for this issue?
Yeah, thank you, Maxima. Personally, in our department, we use mostly stop-start criteria, which we also performed some clinical trial recently, and we also plan the European study with the multimorbidity, which will kind of touch this stop-start criteria. So this is my preferred tool. Unfortunately, I do not know any app or software offering this in an easy way. So basically, one has to learn these points. It's quite many points. So, but these are really logical because if you are knowledgeable about like cardiovascular pharmacology and general internal pharmacology, these recommendations are quite rational and they are in line with what you already know. So I think if one reads the stop-start criteria for a couple of times, I think there's not much need to have any app or software, and it's some clinical sense which helps you guiding the withdrawal process for me personally.
Thank you, Jan. More questions from the audience, please. Thank you for joining our webinar. I think that we indeed raise awareness again regarding this significant clinical problem, namely polypharmacy. Actually, we prepared also some MCQ for self-assessment, but I'm not sure. So I'm sharing the screen with my question. So How many of the older adults take 5 or more medications per day across Europe? So you can answer using chat. So which answer is correct? Do you remember? Actually, we have quite good number of participants, and this was 70 in the beginning. Yes, so now I see we are 60 here. Thank you. First question is correct. So it ranges between third part and up to 50%. So, but correct to the most reliable studies will be 25–40%. So, and one more relevant question was about definition, and it is in line with the question that Maxima asked, this is about polypharmacy definition. So when we start to think about maybe a risk of inappropriate use of medications, risk of polypharmacy related adverse effects or adverse reactions. So whether number matters or duration matters. So also feel free to answer using chat. So indeed, this answer number 4, all of above, is correct. Yes, so we still have no specific definition, sorry, but this cut off might be 5 and above. So when 10 and above are considered to be correct, 11 and above are considered excessive. Yes, so, and these numbers I would like you to remember. So, and once you have patient who takes 5 and above medications, revise time period that is available. So follow recommendations that Professor Václavik shared with us, re-evaluate indications, dosage, duration, reason of indications, remember whether patient belongs to vulnerable patient group, and so on. I think that we are in the very beginning of this very important talk about multimorbidity and multimorbidity related polypharmacy. So thank you again for joining. And now I am to close the webinar. Thank you for being a part of this first spring webinar. Wish you the very best, stay safe, and be very critical when prescribing medications.
Okay. Thank you. Have a nice evening. Bye-bye.
Thank you. Bye.